Now, if it was, this is C2 and C3, so the exiting will be C3, not C2. It's just to know the difference of the roots so that you know which territory might be affected if you know the dermatomes, sensory, or which nerve roots, which part of the muscles are affected. Now, these are examples of MRIs, T2 MRI, okay, because the CSF is white. This is a T2 showing the cord. You can see the cord here surrounded by CSF and the vertebral body, okay. This is at level of the disc, okay, and these are the uncinate processes of the vertebral body, and this is the disc, which has different appearance. Spinous process, the facets, because it articulates with the inferior and superior part, superior vertebral bodies and inferior one, and the exiting roots, they will go from here, okay. So if this gets bigger, it will compress the root. CT, this is a spinal canal, okay. You see the foramen transversarium, the pedicle is here, the lamina is here, and the articular surface. It's the same. So this is the sagittal view. Sagittal, you can see the alignment. You can see the CSF surrounding the cord. You can see the cord and the medulla oblongata here and the craniocervical junction. It's good to show also the discs, okay. C71. And these are the facet, the articulation. They should be aligned and covering each other. So, for example, this is patient with left arm pain. And for example, you see here this part. Look at this foramen, narrow foraminal exit, and this one. You can see that you have a narrowing. This is on the right side, and on the left side, you have this. So we can see different pathologies, okay? So we need the clinical information sometimes, but we see also sometimes different pathologies that are not necessarily similar as the clinical information. Maybe the patient, you can see the compression here is more severe than this one, but both are narrowed, okay? But you can see this one is more severe than this one. So it's more affecting the left more than the right, but even the right side is affected because it's like when you have degeneration, it affects multi-level. It does not affect a single level. Thoracic is a little bit simpler. So this is the frontal view. You can see the alignment again. You see that the patient is symmetric. Go to the midline and see the spinous processes. And then you go laterally, you can see the pedicles. Here we can see the pedicles better than the cervical spine. You can see the pedicles, which are these rounded structures. And in between, you can see the disc spaces, okay? So the alignment is very important because if you have any fracture and displacement, the patient should be in a very good position. So the technicians, when they position patients, they try as much as possible that they do a good positioning. So when we see lateral displacement, it will be significant and we can judge over it. The lateral view, again, you can see the alignment, the anterior vertebral line, the posterior vertebral line, the discs are well aligned. Okay, and here we have limited visualization of the pedicles, and we can see the spinous processes here a little bit, but this is the projection of the ribs that cover a little bit the posterior arch of vertebral bodies in this thoracic spine. The lateral view, okay, this is the vertebral body, and it has articular surfaces here, okay, you can see them. So you have the body, you have the intervertebral discs, and you have inferior and superior. These are costal articulations for the ribs, and the intervertebral foramen, which is here, and very long spinous process. On the superior view, okay, this is it has two articulations with the ribs. One here, which is the costovertebral joint, the rib with the vertebral body, and the other one here, the costotransverse joint, goes with the transverse process of the vertebral body, and the spinal canal in the middle. You can see here. So this is one articulation and second. So costovertebral and costotransverse articulation. And these are the facets. This is superior facet, and the inferior facet is here. This is just to show the deformity of vertebral bodies. For example, this is one vertebral body, but you can see here like there is depression from both sides. Okay, this is like a compression fracture. Okay, it's deformed. And you can see with time it collapses more. This is patient with osteoporosis, so the bone structure is very soft, and since it's taking the weight of the patient, and with this fracture you have collapse of the vertebral body. So it's just show that a simple x-ray can give a lot of information. This is another example of a compression fracture, but you can see better, for example, here that part of the posterior vertebral body is prolapsing posteriorly into the spinal canal. So in here it can compress either the cord or the conus, depend which level it is. This is probably at level L1, L2. So we're close to the conus medullary, to the conus. But you can see the decrease in height, the compression and prolapse of the posterior part of the vertebral body, which is here in the axial planes. This is the 3D reconstruction of this thoracic spine. You can see the reduction of the spinal canal. You can imagine if there is a cord here, it will be really compressed, but this is lower than the level of the cord, but it's showing very nice reconstruction. Lumbar spine, vertebral body are a little bit bigger. Again, the same principle, the spinous process should be in the middle, okay? And you can see the pedicles from each side. So this is, we can see the alignment of the spinous processes and the pedicles. You can see the morphology of vertebral bodies. You can see the intervertebral discs, okay? This is the frontal view. And this is the sacrum. And the roots, they exit in this part laterally from both sides, okay? This is from the frontal view, and this is from the posterior view, seeing, just imagining the exit of nerve roots. The lateral view, again, the anterior wall of the vertebral bodies and the posterior wall, they should be aligned like if you draw a smooth line. If there is one moving anteriorly, this is some kind of subluxation, okay? So vertebral bodies in the lumbar, this is the sacrum, this is the intervertebral foramen, and these are ribs in the T12 rib, okay? And this is the joint, this is facet joint between L3 and L4, inferior facet, superior facet, they articulate here, this part. Again, another illustration, frontal and lateral view, showing midline spinous processes. The alignment of the pedicles are in the middle. The laminas are here. These are the laminas are here. The pedicles are these transverse processes. You can see them. In the lateral view, these are the pedicles. Okay, these are the facets that you can see. The articulation. The disc spaces are here, and the spinous processes on the back. This is not well illustrated here. Another view, the same, the body, the transverse process, the superior articular process, inferior articular process, spinous process. This is the inferior vertebral notch that will constitute with the other part, the intervertebral foramen, okay? Which you can see here. This is the intervertebral foramen. It looks like a whole key, yeah? Like a keyhole. This is how it looks like. And here we did the difference, we injected some contrast into the thecal sac. So this is without contrast. You can see the alignment of the vertebral bodies. So where is the thecal sac? It's in here. So behind the vertebral body, the thecal sac is here. And the roots, they exit through these parts. But in between, don't forget this is a lateral view, some projection of all what you see in the lateral. So this is the CSF space. What you can see, the line here that is black, these are roots, okay? These are roots that they're going down. But you can see here, for example, that there is a disc compression here on the thecal sac. You can see it. We can do oblique views to see if it's compressing the nerve, but here it looks like it's just in contact, okay? So a lumbar puncture, we have to do a lumbar puncture to get the contrast in here. So it's a small spinal needle that usually goes between L4 and L5, so you can feel the spinous processes and put a needle through it. You go through the ligament here, and you feel resistance. Once the resistance is gone, then you can check if you have CSF fluid coming back, and then you inject the contrast. And it can show the impressions of the discs if they are compressing the nerve roots. This is the all. We don't do this anymore because MRI is showing us very nicely the CSF and show us this, the roots. We can see the sagittal planes laterally, so we can see the exit of the roots if they're compressed. We can do axials. So MRI can give us almost all information that we see in the myelogram. The only difference is that MRI, the patient is lying down, so the patient is not weight bearing, so he's not standing. When do a myelogram, you can do it while the patient is standing, so weight bearing. So you can see, for example, an overweight patient, he can have more compression on the disc and maybe compressing the root. So this is one small disadvantage, but it's a big advantage that you don't have a needle inside. There's no risk of breach or infection or CSF leak or things like this, okay? The body, vertebral body, pedicles, transverse process, the articular surfaces, spinous process, posteriorly the lamina and the spinous process. It's just the same, the same anatomy, but different morphology. Difference between child and adult, okay, you can see that there is some part of nuclei in the vertebral bodies are not well attached to the superior corner, sometimes inferior corner, so that's why they're not as sharp as in adults. And the other thing is that the sacrum is not fused, okay, you can see the adult sacrum here and a child, so the fusion of the sacrum, it's a little bit late in adolescence and even adulthood, so the fusion, it becomes in adulthood. So this is the sacrum in the frontal view, but frontal oblique to see the sacrum, and we can see the sacroiliac joints here, and these are the sacral foramens, okay? This is the appearance of it in MRI. We can do oblique views like this. We do the cut like this. It's like sagittal oblique, so that we can have this appearance. And these are the roots, and these are the vascular structures that go around the root, okay? You can see it. This is the sagittal view, the disc spaces, okay? You can see the roots, they are passing here and they will exit laterally. The coccyx, which is the tailbone, okay, it can be from 3 to 5 elements. They can have different morphology, they can have subluxation, so this is how it looks, the appearance on the lateral view. Okay, so it went fast, but this is an introduction in anatomy, and we'll go a little bit to pathology, and we'll see mainly trauma and a little bit of other pathologies, but mainly the trauma. Any questions or any remarks from your side? Do you still hear me? Can somebody? Okay, everything? Okay. So let me check. Okay, very good. So we will continue. So we'll go to part 2. Part 2, the spinal trauma. The majority are seen secondary to road traffic accidents or, of course, sport accidents, okay? Again, we have seen the anatomy, but just a reminder, the different lines, the anterior vertebral line, the posterior vertebral line, the spinolaminar line. So the lateral view should see these lines, and the frontal, I told you have to see the pedicles, the lateral masses, and we'll see something specifically to the C1, C2, or C0, C1, C2, C2, we'll see it separately. So the precervical soft tissue, the anterior vertebral line, posterior vertebral line, spinolaminar line. So concept of 3 columns for spinal fractures. The 3-column concept. So initially described actually by Francis Dennis, and presently CT is mandatory for an accurate classification, but the primary description was on simple X-rays. Initially developed for classification of thoracolumbar spinal fracture, can be also applied in the lower cervical spine. C1, C2, as we said, separate. And it's the same in the other. We will see what are the concept of the three lines. So vertebral column divided into three vertical parallel columns based on the biomechanical studies related to stability. Instability occurs when injury affects two contiguous columns. So these columns are anterior, middle, and posterior. Okay, three columns. So if two are affected, we consider that this is unstable fracture or unstable injury. What is the anterior column? So the anterior column is starting by the ALL, which is anterior longitudinal ligament, anterior 2/3 of the vertebral body and the disc. Okay, the middle is from the posterior 1/3 of the vertebral body and disc till to the PLL, the posterior longitudinal ligament. Posterior column is everything behind the posterior longitudinal ligament. So the pedicles, facets, ligamentum flavum, and neural arch, and interconnecting ligaments. So C0, C1, C2 are separate, different fractures. We will see them separately. And then you have flexion injuries, rotational injuries, extension injuries, and vertical compression or burst fractures. So flexion injuries, we have a simple wedge fracture. You can have a teardrop fracture, Clay-Shawler's fracture, atlanto-occipital, atlanto-axial dislocation. We'll see it separately with the C1, C2 and C0, C1. Bilateral facet dislocation, odontoid fracture. Again, this is C2. And uncinate process fractures. We'll not see them all. We'll see the most important. Simple wedge fracture. What is a simple wedge fracture? You can imagine you have a compression fracture, so you have a flexion injury, anterior superior aspect of the vertebral body. So it's compressing the anterior superior aspect of the vertebral body. So if it's affecting only the anterior column, okay, so generally stable, unless associated if you have a severe flexion and then you have a posterior ligamentous disruption, then this is unstable because this will be affecting the posterior column, so you have two columns affected. So this is like a wedge fracture. This is a flexion injury, so this part is wedged, but imagine that you have a more severe flexion. Okay, you can have a disruption of the ligamental elements here, and then this is it will be unstable. The chance fracture, which is a severe flexion with distraction, like if you have a seat belt, for example, and the body is part of the body is being held by the seat belt and the other superior part is flexed, hyperflexed, you can have disruption of the ligaments here, and there is a fracture that is horizontal through the pedicle. Okay, this is the chance fracture. You can have also like associated rotation, the burst, which is a compression fracture. Okay, this is a vertical compression. So you don't have to see the other types. Okay, a simple anterior wedge compression fracture. This is a simple one. Okay, very slight depression of the superior end plate. Compare this one to this one, very slight, but you can see the superior anterior corner of the vertebral body is slightly irregular and it's going anteriorly. Okay, this is a simple wedge fracture. Posterior vertebral line is preserved. Okay, and the disc spaces are preserved. Okay, here this is simple fracture. Usually we don't do anything, but we have an explanation maybe why this patient having pain, and you can target it with this CT if there is any needed more investigation to see it. Now the teardrop fracture is a little bit it's a flexion, but it's a little bit specific. So there is posterior ligament disruption. So you have PLL is affected here and anterior compression. So you have the posterior longitudinal ligaments affected. You have anterior compression fracture of the vertebral body, which results from the severe flexion injury. So a simple wedge fracture, it's not affecting the ligamental injury, but when you have a teardrop fracture, that means that the flexion is more important and it has caused a ligamental injury. So you have a hyperflexion associated with a compression. An example is diving into shallow waters, okay? And then you have severe flexion of the neck. So what do we see? Of course, it's better seen on the lateral view, because you want to see the anterior teardrop. So you have the prevertebral swelling here because you have a fracture anteriorly, then you have a small hematoma, you have prevertebral swelling associated with anterior ligamental tear. So both you can have affecting both anterior and posterior as well. A teardrop fragment. So we have seen small teardrop anterior superior. So you have a teardrop fragment from the anterior vertebral body, avulsion fracture. Posterior vertebral body can have a subluxation into the spinal canal. So we'll see an example. Spinal cord compression, if it's in the level of the spinal cord, from the body displacement posteriorly, and you can have fracture of the posterior spinous processes. So this is unstable, okay? Example, okay, so you have like a hyperflexion injury that is severe. So if you have a hyperflexion, you can imagine what will happen to the ligaments here posteriorly. So the interspinous, maybe the ligamentum flavum. So you have, this is a disruption. You can have fracture of the spinous process, but because of this flexion as well, you can have a disruption of the anterior ligament, anterior longitudinal ligament, as well as of the posterior longitudinal ligament. Now, associated to this, you can have with this flexion, since there is a fracture of the ligaments here, you can have this part can go posteriorly like this, okay? It might be adjusted here if the patient regain position, but it's still very unstable if these elements are disrupted ligaments. So there is nothing holding. So this part can go posteriorly. There is nothing holding. Okay, so this is important to see the ligamental injury. And for this, MRI is much superior to CT scan. Okay, to see the ligamental injury. What you see is to see that you have the hematoma. Hematoma in MRI, you'll see it posteriorly and anteriorly. And of course, you will see the cord, which is lying here, if it's compressed or not, or even sometimes an injury of the cord. This is an example of the MRI and X-ray. So this is the anterior teardrop. There is thickening of the soft tissue anteriorly. Okay, this is now, of course, probably they have put a collar and adjusted the alignment because we position the patient in a way that he does not flex anymore. But you can see indirectly here with the flexion that happened, you have elements have compressed the cord here, and then you have edema in the cord. Okay, there is an injury of the cord at this which is lower down, not necessarily in the same. It can be at the same level if you have a posterior subluxation of this part continues back. It might injure the cord at this level, but this patient is not young. You can see that we have degeneration, and probably here there is some degree of spinal stenosis. And with this fracture that happened, there is malalignment and there is a little bit of impression on the cord with injury at this level. So you can have different pathologies that will end in different, give you a different result, not a simple pathology, okay? Facet dislocation, bilateral facet dislocation. So it's a complete anterior dislocation of the vertebral body resulting in extreme hyperflexion injury. It is associated with a very high risk of cord damage. So if you have an extreme flexion of the head or neck without axial compression, so the other one we had a little bit of axial compression. So you have a complete anterior dislocation, affected vertebral body by half or more of the vertebral body. So you'll see that the vertebral body has been displaced more than half of the anteroposterior diameter. We'll show you the example. Disruption of the posterior ligament complex and anterior longitudinal ligament. You have a bow tie appearance or bat wing appearance of the locked facets. So this is really a severe injury. It requires a high degree of force and best seen on the lateral view. So what we'll see in the lateral view, the vertebral body above displaces anteriorly by at least 50% of the anteroposterior diameter of the vertebral body. So this is what we call the facets. They appear locked. Okay. For example, you can see the alignment here, it's disrupted, and this vertebral body has been displaced more than 50% of this anteroposterior diameter. It's reaching to the border, okay? Now these are the facets, and this is the other facet. Now look at this facet and this facet, how they articulate. Now look, this one has been, went anterior to it. Imagine the cord, what's happening here. So there's severe, it could be a severe injury to the cord at this level. This is another view, more than 50% anterior displacement of this vertebral body. This is C5 over C6, and these are the facets. They are completely locked anterior to the inferior facets. There is no more articulation. These are normal articulation of the facets, and this is the facet they have jumped and went anteriorly, so that you can imagine this requires a very extensive flexion force. Okay.
دكتور السلام عليكم.
You can. Yes, عليكم السلام.
الفاسيت هل لازم تكون كلها في نفس الليفل؟ يعني الفاسيت لما يصير بايلاترال هل لازم يكون كلها superior ولا ممكن يكون superior و inferior؟
This is the facet that has jumped anterior to it. ما فهمت السؤال.
هو لأنه في زوجين فاسيتس، اثنين superior.
Both. هنا this is bilateral. Okay, bilateral locked facets. Okay, when you have this movement more than 50%, this is bilateral. Okay, unilateral you will not have this appearance. Okay, we'll see the unilateral separately. So when you have a displacement with this force, okay, you can see both facets here. Okay, this is more than 50%. This is, you have to suspect and call it bilateral locked facets. Okay, we'll see the unilateral later. This is unilateral. So this is the facet joint dislocation, rupture again of the apophyseal joint and the ligaments. Is similar, it's a simultaneous flexion, but there is associated rotation here. So it's not affecting the degree of flexion in both facets. It's not the same. In one side, it's more than the others. So again, the lateral view. So we have anterior dislocation, the same thing of the affected vertebral body, but it is less than half of the vertebral body anteroposterior diameter. So I have discordance of the rotation. Okay, because if there is a rotation, the movements of the facet, one is more affected than the other. So facet with intervertebral foramen, we can see it on oblique view as well, or you can see also widening of the disc space and the bow tie appearance. But unilateral, we consider it stable, not like the bilateral. For example, here you can see both facets. Okay, they looked here, they're covering, they're not covered. For example, this facet and this facet, you see they are covering each other. This one, they are not really covering each other, reaching to the border. Okay, they're not the same level, but look at the displacement of C6 over C7. We don't have the same displacement. So usually when you have a displacement more than 50% of the anteroposterior diameter, we suspect bilateral locked facets. Here you suspect unilateral. Okay, look at this maybe more clear. Again, you can see the facet alignment here. These are the normal articulations. Okay, you can see here, and you can see they're not at the same level, but the displacement, you see, it's less, and it's like maybe 25, 30, 40%, less than 50%, definitely. You have anterior displacement of the vertebral body, it's less than 50%. The interspinous space has increased. That means that there is a ligamental injury here, but usually these are stable injuries when it's unilateral. Of course, CT will give you more details. When you have something like this in a trauma, you can do a CT scan to evaluate if you have associated fractures. Since there is a rotation, you can have free bony fragments. So CT is important as well. But these are the findings in simple X-ray. Clay-Shawler fracture, it's a simple fracture, stable, which again, we call it to the old Clay-Shawlers that they have these flexion injuries of the spinous process, but this is how it looks like. It's just showing it, it's like historical fracture, not very common actually. This is another Clay-Shawler fracture, okay, which is usually stable. and you said it's affecting one part of the posterior, and it's not really affecting, and you can have maybe this ligamental injury here, but other ligaments are preserved and there is no malalignment. The other all lines are still preserved. Now we'll go to the craniocervical and C1, C2. And these are a little bit specific, and we'll see some specific fractures. They can be highly unstable, maybe associated with odontoid fracture. Odontoid is, we remember the dens, which is part of the C2, which is the axis, okay? So again, we'll come back to the distance. The distance here is small, usually between the C2 anterior arch of atlas. Now, if it's widened like this, okay, we have seen the rheumatoid arthritis can affect the ligament, okay? You can have it enlarged, but you can have it also in trauma, okay? So when you see something like this, you have to suspect the trauma, if it's in the context of trauma, of course. So this is widening of the predental space. So this is the dens, predental space, or distance between anterior arch of atlas and dens, as you wish. So odontoid fractures should be suspected if there is anterior tilt of the odontoid. So we have seen the odontoid process, it looks straight. So if you have a tilt anteriorly, posteriorly, you should suspect a fracture. The loosened